Hello, and good morning or good afternoon. I'm Dr. Yvette Roubideaux, Director of the Policy Research Center at the National Congress of American Indians. Welcome to our webinar today on diabetes and behavioral health comorbidities, advancing the tribal behavioral health agenda. We are so glad you joined us today, and now Sarah Patalski, Policy Research and Evaluation Manager with the NCAI Policy Research Center, will review how to navigate the webinar today.
Hi everyone, thank you so much for joining us. So before we get started, I just wanted to walk you through how to participate in today's web event. As you'll see on the left, we have the interface where you will see all the slides and the entire presentation, and to the right is where the participant kind of user interface is, and that's where we're going to focus in. This is the control panel for each of you. So once you zoom in here, you'll see the orange arrow. This allows you to open and close your panel. Next, we can have you view, select, and test your audio. This is where your information is found. It allows you to join via telephone, which is what we recommend. And this is where you find the dial-in information as well as the access code and your unique audio PIN. You are also able to submit text questions to us today through the chat pane. So please feel free to send in the questions during the presentation, and we will make sure to get to them towards the Q&A period at the end of the event, which will save 15 minutes to 20 minutes towards the end of today's webinar for Q&A with the presenters. So please feel free to start sending in those questions at any time, and we will raise them later. You may also raise your hand during the Q&A, and we can then unmute your line. Everyone is now currently in mute or listen-only mode, and that's just to reduce any background noise so we can all hear clearly. This is just a quick reminder also to let folks know that this webinar is being recorded, and it will be available on our NCAI YouTube page at the end of the day. You will also receive a follow-up email within 24 hours with the link to the webinar recording. And now back to Dr. Roubideaux for an overview of today's webinar.
Thank you, Sarah. Well, this webinar is based on NCAI's current project with SAMHSA entitled the Tribal Behavioral Health Agenda Implementation. We are so grateful for this opportunity to help advance the implementation of this great resource. The purpose of the project is to basically engage tribal leaders on implementation of the Tribal Behavioral Health Agenda, or TBHA, and to help advance the behavioral health of American Indians and Alaska Natives. The project outcomes include a paper on diabetes and behavioral health comorbidities, the topic of this webinar, and other webinars and podcasts related to the TBHA. I would now like to introduce Michael Kaczynski, Project Officer with the Office of Tribal Affairs and Policy in the Office of Indian Alcohol and Substance Abuse at SAMHSA and the Substance Abuse and Mental Health Services Administration. Michael, thanks so much for being here today.
Why, thank you, Dr. Roubideaux. It's been a real pleasure working with you and your team there at the National Congress of American Indians, and it's been a pleasure helping to assist with the development of this project, and we look forward to great things in the future as this project gets dispersed throughout the country and in the halls of Congress and amongst tribal leaders. So we here at SAMHSA are very proud that we were able to partner with you on this project, and wish you all the best.
Great. Thank you so much for being with us on the webinar today. Well, for those of you who may not be familiar with the Tribal Behavioral Health Agenda, it was released by SAMHSA and IHS in 2016. It resulted from conversations and consultation with tribal leaders about the significant impact of behavioral health issues in their communities. This document is a wonderful document, and I hope you've had a chance to read it or can read it soon. It starts with a cultural wisdom declaration, with tribal leaders noting the important role of cultural wisdom and traditional practices in improving the well-being of American Indian and Alaska Natives. It highlights the extent to which behavioral health challenges impact tribal communities. It offers a framework for strategies and priorities to improve the behavioral health of American Indians and Alaska Natives. And it's meant to serve as a blueprint to encourage further collaboration on these issues. So the intent of this webinar is to use one of the recommended strategies in the TBHA to improve national awareness and visibility of behavioral health issues faced by tribal communities. And now I'll throw it back to Sarah to talk about some of the resources available or coming soon from this project, and then we'll get back to the topic of today's discussion.
Thank you so much, Dr. Roubideaux. So as part of this work, we really wanted to focus in on the framework that was presented by the Tribal Behavioral Health Agenda, which included 5 foundational elements. And so within each of our products that we've been producing, we've really been intentional in focusing on at least one or more of these foundational elements. I'm just going to mention those for those who may not be familiar. The first is focus on healing from historical and intergenerational trauma. The second on the socio-cultural ecological approach to improving behavioral health. The third is ensuring support for both prevention and recovery. The fourth is strengthening behavioral health systems and related services and supports. And the fifth, of course, is raising national awareness and visibility of the behavioral health issues faced by tribal communities. So the first webinar that we just hosted last week featured Dr. Tassie Parker from the University of New Mexico. She's a member of Cherokee Nation, and she is a premier scholar in community-based participatory research, and she has great depth of knowledge on how to navigate depression management in a way that is empowering a local urban Indian community. And she shared that example, and we do have the link available, as you see, the recording at the bottom of this slide. We encourage you all to listen into that webinar. We had a lively discussion about how communities can drive the implementation of care and the integration in ways that is meaningful to them through the integration of culture and other considerations in their clinical practices. The second 2 kind of products that we have launched as a part of this project is part of our Tribal Data Drum podcast series. These will soon be released. We have recorded 2 podcast episodes thus far, the first featuring Dr. Julie Lucero, and this one was about the sociocultural ecological approach. And the second was with Abigail Echohawk, who is the director of the Urban Indian Health Institute, and she helped us focus in on the prevention and recovery support. So please stay tuned and check our website for updates on the release of those podcasts. They're about 20 minutes each, so very easy to listen to on your morning commute, and we encourage you to engage with those. We also want to draw your attention to some sessions at the upcoming NCAI Annual Convention and Marketplace, which will be held next week in Milwaukee, Wisconsin. We have a breakout session that is a roundtable on implementing the Tribal Behavioral Health Agenda in a culturally relevant manner on Tuesday afternoon. And while not part of this project, we also have a related breakout session on tribal data capacity and research futures, focusing on governance, culture, and trust, and that will be happening on Wednesday afternoon. We also have another collaborative effort with SAMHSA that we are incorporating in our youth agenda called the STYL Leadership Academy, or Style Leadership Academy, which stands for the SAMHSA Tribal Youth Leadership Academy. And the purpose is to engage Native youth in developing behavioral health knowledge, engaging with peers, and developing leadership skills to support their efforts in being a generation for change. So these agendas for these events are featured on our PRC website and also on the NCAI Annual Convention website. We have also posted announcements about our events and the NCAI Annual Convention on Twitter. Here's the announcement for the Tribal Data Capacity Breakout Session. And now back to Dr. Roubideaux.
Thank you, Sarah. So back to this overall project with SAMHSA. The work on the overall project is a collaboration of several individuals at NCAI and 2 consultants who are with us today, Dr. Melissa Lewis and Dr. Kyle Hill. They're helping with the paper we're writing on diabetes and behavioral health comorbidities. Dr. Melissa Lewis is an assistant professor in the Department of Family and Community Medicine at the University of Missouri School of Medicine. And Dr. Kyle Hill is a licensed psychologist and associate faculty at the Center for American Indian Health at Johns Hopkins University Bloomberg School of Public Health. So we are writing a paper on diabetes and behavioral health comorbidities, and we're almost done with it, and this is the current paper outline of the draft. Basically, we're talking about current research and status of diabetes in American Indians, along with behavioral health in American Indians and Alaska Natives, and then looking at the research and the current knowledge about diabetes and behavioral health comorbidities. We also will be discussing current efforts to address these issues and also policy recommendations. So today what we'd like to do is share some findings and observations in doing this literature review and working on this subject, and we're really interested in your ideas and experiences before we finalize the paper. And so we were very interested in your feedback on this webinar. So we'll start with the first section, which is a review of where we are at with diabetes in American Indians and Alaska Natives. And in my previous academic work, I taught and wrote a lot about diabetes in American Indians and Alaska Natives. As I look back at some of that work in the 1990s and early 2000s, I noticed how dire the message was to describe the epidemic of type 2 diabetes among American Indians and Alaska Natives, and how we all advocated for progress. At the time, the prevalence was going up. At the time, mortality was going up. And we were urgently wanting to have the new research results that, the complications could be prevented and the diabetes actually could be prevented. We wanted those to be applied to tribal communities. But lately, there's some good news and some promising trends in the area of diabetes in American Indians and Alaska Natives. So many of you know Dr. Bullock. She's the director of the Indian Health Service Division of Diabetes Treatment and Prevention. And I got the chance to hear her presentation at the Diabetes in Indian Country Conference about 2 weeks ago. And it was great to see how she summarized that there are improving trends in diabetes in American Indians and Alaska Natives. And I'm just showing the slide from her talk. I was so excited we tweeted it that day. And if you can't read it, it basically gives great news. The prevalence or the proportion of people with diabetes in an American Indian Alaska Native population, the increase basically stopped in 2011 and has been fairly constant since then. And then for American Indian Alaska Native youth, the rise in diabetes prevalence stopped at least as early as 2006. And if we look at childhood obesity, which is a major risk factor for diabetes, that is also improved. And here Dr. Bullock notes the recent American Journal of Public Health paper that showed the prevalence of obesity in American Indian Alaska Native youth aged 2 to 19 years was nearly constant from 2006 to 2015. And hopefully we've all heard about the great improvement in outcomes related to diabetes complications, such as the decline in early-stage kidney disease, end-stage kidney disease, and the reduction in diabetic retinopathy or eye disease. And so these are clearly promising trends, and it's likely due to the improved and well-coordinated diabetes care in the Indian Health Service programs, as well as the great efforts of the Special Diabetes Program for Indians grantees since 1998. And so it's possible that all these efforts are doing great things in helping us curb this epidemic that I talked so direly about back in the day. But it is really important to note that despite all this progress, there still are disparities in diabetes for American Indians and Alaska Natives. And now is really not the time to rest on our laurels. Actually, it's time to double down towards elimination of those disparities. With the national rates of diabetes still higher overall in American Indians and Alaska Natives compared to other groups, as is shown in this slide from the National Health Interview Survey, and IHS trends data showing that age-adjusted diabetes death rates are still almost 3 times higher than the U.S. all races rates. So there's clearly still more work to do. But many of you probably also see in real life that there's still more work to do. Individuals still have diabetes in our communities, and it has great impact on their own lives, their families, and their communities. And that's why we also need the reauthorization of the Special Diabetes Program for Indians beyond the recent 3-month extension. But more on policy recommendations later. And this is also why the Tribal Behavioral Health Agenda is so important. It's needed to help energize our efforts to keep fighting to reduce these disparities. And just maybe, a focus on diabetes and behavioral health comorbidities will help us make even more progress in the fight against diabetes and the reduction of these disparities. And so now I'd like to turn this over to Dr. Kyle Hill, who will talk about the behavioral health conditions in American Indians and Alaska Natives.
Hi, good afternoon, everybody. My name is Kyle Hill. I'm a psychologist in the Indian Health Service. And so today, we're talking a little bit about the behavioral health conditions, specifically the ones that we focused on in our paper, as well as those kind of highlighted in the Tribal Behavioral Health Agenda. So first off, depression. As a psychologist, I think what I see most often is folks that come in, but they don't meet the entire constellation of symptoms of depression. Most often what people will come in with is to say they are depressed and may not meet the criteria. And so sometimes they fall short of the diagnoses. And so with that, I think when we make the parallel to some of the studies that exist, some of the most often cited studies were some very ambitious kind of psychiatric epidemiological efforts in the early 2000s. And with those, they use kind of like a domain criteria, a very standardized tool to be able to measure depression in a very lengthy interview. And so from that, what we're seeing is that depression rates inside of American Indian communities falls basically within that what we would expect in the general population, although from a community perspective, it seems a lot more ubiquitous, I guess, to say the least. And in my, from what I see and from what I understand from the literature, it seems that a lot of what we see presenting in the clinics is almost like an idiomatic or kind of an idiosyncratic expression of depression, and one particular symptom that we see is loneliness, right? A lot of elders, a lot of community members present with loneliness as kind of the primary issue that we struggle with. And as you can imagine from a collectivistic community, this is particularly kind of a struggle, and somewhat very challenging for anybody to come into the clinic with. And so, coupled with the stigma related to presenting to behavioral health in the first place, I think that people and depression is treated very seriously as someone that is going through that when someone comes into the clinic. And so what we know also about adolescents is that, and as well as their caretakers, is that a lot of depressive symptoms are related to thoughts of historical loss. So basically perceived notions of intergenerational trauma and what they understand that to be. And so some of the I guess it's kind of dated, but about 2008, 2009, there were some investigations that looked at thoughts of historical loss within adolescents and their caretakers. And actually adolescents had thoughts of historical loss, loss of culture, language, land, loss of their elders and caretakers to kind of perceived to substance use. And so a lot of those things we have a large proportion of our communities thinking about, and it's often related to depression. So if there's one thing that I want to leave everybody with in this webinar, in my piece, is that, within every single behavioral health kind of condition that we experience as disparate in our American Indian communities can often be traced etiologically to colonization, experiences of intergenerational trauma and historical trauma. And so, you know, even in adolescents, children, and adults, we find this to be true, you know, and obviously with substance abuse, what we find is that this is often kind of the first coping mechanism for people who are wanting to present to the clinic, but obviously they don't, right? And so oftentimes you'll see someone who is actually just trying to self-medicate. And so with also, again, the stigma of coming into the clinic presenting to behavioral health, we find this to be particularly troubling and challenging for us, because you're often faced with kind of a presentation of more of an acute nature, and you have to triage that accordingly with the folks who come in with co-occurring disorders and a dual diagnosis, maybe of depression as well as substance abuse disorder. And so what we understand about substance abuse also is that the stereotypes are often kind of unfounded within the literature, and particularly around alcohol use and misuse. And I'll visit this a little bit with suicide as well, but what we find is our younger folks are struggling more with substance abuse, suicide, and overall kind of the behavioral health profile of our young people is again troubling. And it's interesting because in other populations you see older adults, middle-aged adults struggling with some of these same conditions. And in particular, we see substance abuse and alcohol use started earlier than other populations in the U.S. general population in American Indians. So as young as 10, 11, 12 years old, we see that there's substance abuse and alcohol use that is kind of in that is greater than the general population. And so this is problematic, of course, because, you know, as you see, our youth at the developmental stage that they're at really don't have the capacity to or the flexibility, I guess, to be able to help themselves, the insight into their problems. And so oftentimes what we see is that presenting to the clinic and in clinical context is that, you know, these youth and it can be as small as children, I guess, is they come in from a recent suicide attempt. And so for suicide in particular, we see, what I've seen is as much as 20 to 30% of American Indian youth have a lifetime suicide attempt. And so this is problematic, is you know, when they present to the clinic, oftentimes, and I've seen that presenting right after a suicide attempt. And similar to the general population, we see that females attempt more often, but males have the more lethal attempts. And so females might be predisposed, or you might see a female with attempted overdose or poisoning, and then you'll see a male with more gunshot wounds and asphyxiation or hanging attempts. So it's not uncommon, again, to see these comorbid presentations or presenting together. Oftentimes you might see somebody who comes into the clinic and says, I don't remember what happened, you know, but their family, their family brings them in after the fact, you know, after the suicide attempt, and says, well, we found them. We found them hanging. And, you know, from there they take him to the ER and stuff like that. So, you know, these issues are not uncommon. And so what I tend to see is that all of these conditions are often occur together, and they're comorbid. So with respect to kind of behavioral health in particular, you know, these are all related, but I think what I want to make certain is that these conditions, for the most part overall, are kind of particularly ideologically related to kind of historical trauma that occurs in the families. And again, if we look at, following from this discussion, is the fact that adverse childhood experiences are so high in our communities. And so if we think about the etiology, the behavioral issues, especially in our communities, American Indian communities, is that up to 60 or 70% of American Indian youth have at least one adverse childhood experience. And so what we understand from the literature on adverse childhood experiences is that it really behaves sort of according to this dose-response relationship, whereas the more adverse childhood experiences our children have, the higher the degree of association with certain behavioral health presentations or comorbid presentations such as depression, substance use, and suicidal ideation. And so really this falls in line with the considerations of what we understand to be almost a stress response and a diathesis stress kind of etiological model or approach, where the diathesis is going to be kind of our predisposition or the inherent biological predisposition to some of these disorders, right? And then the stress response is going to be the environmental stress or the environmental experience that the children undergo. And so this is kind of problematic, because what is happening is that because the increased amount of experiencing these adverse childhood experiences, as well as the younger age at which we're experiencing these ACEs, compounded by the age of the entire population, with as much as almost 50% of our population is under the age of 25 or 30, you see that you could start to lay the groundwork and the foundation with understanding why some of these behavioral health issues are kind of disproportionately affecting our communities. And so, of course, up here we have genetics and genomics. And so just briefly, I mean, when we talk about the diathesis, I think there were a lot of attempts undergoing now, but also I think back to, some of the problems and ethical issues involved in developing those sort of metabolic kind of ways to help facilitate the kind of healing pathways, or I've seen kind of metabolic panels for figuring if some of these medications will work for American Indian people and in the U.S. general population. But we also understood that American Indian people have been approached in a very unethical way historically. So I think there's definitely efforts to return to some of these aspects of genetics and genomics. And I recently read a report that the Tuba City Regional Healthcare Center is thinking about opening up their own cancer hospital to explore some of these, because the cost of actually referring their people out is becoming pretty problematic. So I think there's some efforts underway to kind of return to some of these genetic and genomic kind of studies to be able to help the people in some of these conditions. So, I guess that's all I had to say for this part. And, the focus of the paper is, of course, behavioral health, but as well, it's how behavioral health, and particularly the exposure to trauma as kind of a social determinant of health, leads to other chronic conditions. And so what I'd like to do now is turn it over to Melissa Lewis to talk about the comorbid conditions and presentations of American Indians with diabetes and depression and other conditions. Thank you.
All right, thank you, Dr. Hill. And I'll kind of build on what you just spoke about. You had laid a nice foundation about mental health in American Indians, and I'll talk now about the relationship between mental health and diabetes in American Indians. So there's really been, and I'll kind of just do an overview here of the state of the literature, what we know now. There's been 2 big reviews looking at the relationship between mental health and diabetes in Native populations. And one large outcome was that we need more studies. And the second large outcome is that there is a relationship between mental health disorders and prevalence of type 2 diabetes in American Indians. And this particular relationship is stronger than it is for non-Native populations. And in one study of youth who have type 2 diabetes, around 17% screened positive for depression. So another study kind of looked at psychological distress, and they found that among those Native folks who have diabetes, those who had psychological distress had increased weight, higher BMIs, and higher A1C scores, higher blood sugar. And to kind of go a little bit further, they found more evidence to demonstrate that depression and depression symptoms in particular is related to increased A1C scores. So going a little bit deeper into what Dr. Hill spoke about, if we know that Native people experience more diabetes, if we know that Native people experience more psychological distress and are diagnosed more likely with mental health issues, what is the source of that? And Dr. Hill talked a little bit about ACEs, so I just wanted to share with you that we do know that Native people have significantly more adverse childhood experiences than non-Native people. In fact, if we look at the percentage of the population that has 4 or more, non-Indigenous people have 6% of the population experience 4 or more, and about a third, 33% of all Native people experience 4 or more ACEs. And what I want to share with you is that if anyone has 3 or more childhood adversities, they are 1.5 times more likely to have diabetes, to have severe obesity, and they're 2.2 times more likely to have heart disease. So that's a significant risk factor for our population. The second, I guess before I move on, another interesting topic that Dr. Ann Bullock speaks about in her lectures are moving on from ACEs, other childhood health and fetal origins of diabetes. We know that for those folks that experience a severe or chronic stressful event in the first and second trimester, they are more likely to have diabetes, increased risk of obesity as a young child and into their teen years. The reason why this is so important is because we know that Indigenous women are the most vulnerable and victimized group in the nation. They're more likely to experience domestic violence, physical assault, and sexual assault than any other group. Moving on to historical loss, Dr. Hill spoke about some statistics that demonstrated that over 50% of adolescents had multiple thoughts about historical loss every day, and about a third of all adults report multiple thoughts about historical loss. And why that's so important is because those thoughts are associated with an increased risk for depression, suicidal ideation, and anxiety. So this third kind of chronic stressor that we need to be aware of for Native people is discrimination. Compared to the overall U.S. population, we know that Native people experience more traumatic events, especially related to their loved ones, and are more likely to be victims of physical attacks, racism, and discrimination. So what does that mean for risk for diabetes? Well, we know that Native people who have PTSD are more likely to report depressive symptoms than those who do not experience post-traumatic stress. And in a study that looked at stress, including discrimination, experiences of discrimination, Native people who have that larger stress burden and experience are more likely to have type 2 diabetes. So what is the relationship? I have a model up here that looks at what is the proposed relationship between stress and metabolic disease. And just, I'm using the term metabolic disease because it does encompass heart disease, stroke, and diabetes. It's a cluster of conditions that includes increased blood pressure, high blood sugar, high cholesterol, and excess body fat. So what we know is that psychosocial stress is related to metabolic syndrome, and we know that psychosocial stress is related to kind of stress physiology. And this occurs through an inflammatory process resulting from chronic stress, and it drives all these health risks. But studies in indigenous communities have found that inflammation, that physiology I'm talking about, is related to increased metabolic risk factors. So we know this is happening in the general population and in the Native population as well. So again, looking at this diagram here, stress increases metabolic disease risk factors, and the experience of diabetes also increases stress. They're working, one increases the other. So clinically, when we think about Dr. Hill in his workplace, we know that we should start thinking about, if someone is diagnosed with type 2 diabetes, this is the time to start assessing for depression, and vice versa. If someone has high psychosocial stress or experiencing depression, they're at more risk for type 2 diabetes. So that is the time to start working with your collaborators. In fact, stress has been elevated even above cholesterol as a predictor for heart disease and diabetes. However, I have a little caveat here. There we go. Part of the relationship is always seems to be explained by mental health, in particular depression, sometimes anxiety. But when someone experiences psychosocial distress, if the result is depressive symptoms, those relationships to metabolic disease, including diabetes, and those stress physiology outcomes become even stronger. So, and mental health is critical in assessing, preventing, and treating metabolic disease, including diabetes. So I'll move on to what we know about interventions. So among the very few studies that aim to reduce type 2 diabetes and mental health symptomology simultaneously, we know that there's one program that is home-based and targeted youth with type 2 diabetes, and 12 months after their intervention, their participants had reduced depression, hypertension, and BMI. And they used a kind of a psychosocial model to do some type 2 diabetes education. So there's some more studies that we should be getting results back on pretty soon around the diabetes prevention programs. But there's not really a lot. Among the studies that do look at reducing type 2 diabetes risk factors, the most effective ones incorporate three things: case management, social support, and cultural adaptation. So I wanted to just briefly talk about a few successful interventions that focus on cultural adaptation, but maybe didn't quite focus on reducing mental health symptomology at the same time. One study by Dr. Choi found that if you tailor a smoking intervention, we know smoking is a risk factor for metabolic disease, but the tailored intervention versus a non-tailored intervention, culturally tailored, there was quite a big difference. Intervention that was created for the general population that was delivered to Native people resulted in 17% of that group having quit rates, but when they did a culturally tailored intervention, it almost doubled. It went up to 28% quit rate. So that was a pretty impressive. One study that occurred almost 20 years ago now, looking at their group called the Pima Pride, they did 2 different groups wanting to reduce risk factors for metabolic disorder. One group did cultural activities, history, and language only, and the other group did training for exercise and diet, which is what we usually see in a clinic, something that your physician will tell you to do if you are diagnosed with type 2 diabetes. Well, the PIMA Pride intervention, the cultural intervention, had better outcomes around weight gain and around blood glucose levels. So that's very promising. And lastly, Dr. Kaholukula at University of Hawaii has been working on a hula study where participants do a cultural intervention where they elicit knowledge, culturally specific knowledge from elders and experts in the community, and do 12 weeks of hula and cultural learning. And this has shown really exciting results in reducing blood pressure. So thank you for letting me share that with you, and please let me know if you have any questions.
Great. Thank you, Dr. Lewis, and thank you, Dr. Hill, for some great perspectives on the subject of diabetes and behavioral health comorbidities and the impact of behavioral health conditions, and some of the interesting experiences and information that you have to share, really unique, and we're really grateful for the information that you've been able to share today, and really grateful also for your collaboration on this paper that we're working on. So we also in the paper are focusing on what current efforts there are to address diabetes and behavioral health comorbidities, and we're actually glad to see the Indian Health Service just put out a new RFA for funding to address the integration of behavioral health into primary care. So that's also promising. We end the review of this, the current status of diabetes and behavioral health comorbidities with some policy recommendations. And this is our draft list is listed in the slide where we're sort of looking. And basically it's more of everything, but consistent with the tribal behavioral health agenda, we need more awareness and attention to support behavioral health issues in American Indians and Alaska Natives as we're making the case, especially to individuals with diabetes. And one of the big goals of the TBHA was to encourage more collaboration among federal agencies, along with more collaboration to state and local levels on these issues in consultation with tribes. And in fact, we encourage tribes to take the TBHA as a resource when meeting with the federal, state, and local stakeholders to help encourage more ways to advance the goals of the TBHA. And it's clear that behavioral health issues have a significant impact on American Indian and Alaska Natives and their communities, and coupled with diabetes, the needs are even greater. And the one thing that we want to emphasize is, in addition to more funding and efforts and programs and promising practices, we definitely need more research on in this entire subject as well. So now we have a few minutes left in the webinar. What we'd like to do is see if those of you attending the webinar today have any questions or feedback for us. I know this has just been a very short review of what we're doing, but are there areas where you would like to see more research in the area of diabetes and behavioral health comorbidities? Are there examples of best and promising practices? Do you have any advice on policy recommendations? And what's the impact of raising awareness of these issues where you work, or any other questions? So I'm going to turn it over to Sarah, who will give instructions for how to pose a question, and we'll try to answer them as best as we can with the remaining time.
Hi, everyone. So again, this is just a brief reminder to let people know that you're more than welcome to type in a message into the chat pane in the user interface. So please feel free to make use of that, send in your questions. You're also welcome to raise your hand and we can unmute your line if that's a little bit easier for you. So we will stay posted that way.
And we'll have all of our panel on alert to help answer questions or comments or suggestions.
So one question we just received is from the NCAI national perspective, what is something that, what are the next steps for SDPI reauthorization? Could you share a little bit about that?
I'd be happy to. The Special Diabetes Program for Indians, as I said before, has some amazing programs that are tailored to their local communities and involve a lot of incorporating local traditions and cultural knowledge, and have really done in both IHS, tribal, and urban Indian health programs an outstanding job. But our work is not done, so National Congress of American Indians is collaborating with National Indian Health Board and other organizations to try to help encourage that the Special Diabetes Program for Indians gets reauthorized. It's currently reauthorized for 3 months only, and so we know there's some activity around the CHIP reauthorization, and the House introduced a 2-year reauthorization. We're hoping to see more from the Senate, but that's where we're at on the SDPI reauthorization, and we're certainly encouraging everyone to tell the story of how this program has made a difference.
We have a question about diabetes and depression as it manifests in specific subpopulations. There's an interest in veterans in particular. I wonder if Dr. Kyle is still with us, if he could share a little bit about his work in that area.
Yeah, sure. I think what I see often is that, people will come into the office and they haven't really had a screening, or they haven't been seen by a primary care provider. And so from what I understand about the literature, what often happens is that, it's kind of a chicken and the egg or horse in the cart, trying to find an analogy, but it's not really understood too well about what the function is and what that relationship is between depression and diabetes. But what we do understand is that often what occurs, when you have the comorbid presentation with depression and diabetes, is that you'll often have a non-adherence or a difficulty with adhering to the often very regimented treatment for diabetes. Especially type 2 diabetes being so high in our communities. So, kind of like Melissa said, or what Dr. Lewis said, was you often have to kind of act as an advocate and a case manager within the office, especially in behavioral health. And that may mean kind of trying to take an approach where you function as almost like an integrated practitioner. You might do a warm handoff and actually set up referrals and consults with the primary care provider to do things like thyroid tests and screens, as well as kind of to look at what their blood glucose level is. Because often these people haven't had a fasting glucose test for quite some time, if ever. And so, usually that's the first kind of order of service or treatment for someone who comes in for depression. And then after that, you kind of treat accordingly as kind of a traditional behavioral health manifestation of depression. So yeah, I hope that answered your question.
Great. Thank you so much, Dr. Hill. We have a question from Dean Seneca at the Center for Disease and Health Control, CDC. What are the best methods to raise awareness of mental behavioral health in tribal communities? And how do we incorporate a cultural component into prevention? So I might actually refer this question to Michael Kaczynski, but if you'd like us to do a group response, we're happy to do that as well. So again, it is, what are the best methods to raise awareness of mental behavioral health in tribal communities? How do we incorporate a cultural component in prevention?
Hello? Can you hear me?
Yes.
Yeah, I sure would like to have others chime in, but certainly, working with the tribal health departments, you know, at the local level, you know, developing their own culturally appropriate programs for whatever you know, local community they're dealing with, because they're all going to be different, you know, whether in Hawaii or Alaska or the lower 48. So, so unique to that particular culture, and that I think would be the critical thing when working with the local leaders, local health department, local behavioral health people.
And it's great to hear you say that, because you are at SAMHSA, which has a lot of great programs that do allow for some of that local adaptation for culture and traditions that have been very helpful in tribal communities. So we appreciate that. I want to point out in the Tribal Behavioral Health Agenda, there's the cultural wisdom statement signed off by the tribal leaders. And the intent of that is to really recognize and declare the importance of cultural practices and traditional wisdom, cultural wisdom and traditional practices in these types of programs, because they're so essential. And like Dr. Lewis said, there's now emerging evidence that if you do that, you get better outcomes. And that's certainly another area that we hope to see more evaluation and research in, with the caveat that some tribes may not want to share the cultures and traditions. And so we have to be respectful of that as well. But it's an exciting area, and thank you for the question, because it's definitely an area where we need more work, because it's an area of hope for addressing these issues.
Along those lines, we had a question come in about cultural revitalization efforts. And I was wondering if Dr. Lewis might address some of the work that she's been doing around efforts such as the Cherokee Nation's Remember the Removal Bike Ride, and how we might be able to learn from those opportunities in terms of comorbidities and addressing chronic and behavioral health conditions.
Well, I can talk a little bit about it. So those are not published results yet, so I don't have permission through the Cherokee Nation IRB to talk too much about the results, but I could say that maybe through the literature reviews that I've done of other programs, that both, you know, there's two kind of studies, one in which you do interventions in which you integrate culture or do cultural revitalization, like basket making or language lessons, for example. And there's other studies that just look at, do people participate in traditional cultural activities? And we know those that do have improved academic performance, improved positive mental health, reduced substance use, and improved physical health. And that goes both for youth and adults. So what's really interesting and powerful about culture is that we see improvements both in mental health outcomes and in physical health outcomes. And hopefully I can share some of the exciting results of a program I've been working with my own tribe, looking at Cherokee-specific cultural learning around history, language, genealogy, and kind of historic and cultural place-based learning, kind of demonstrating the importance of that as a core component for improved health. And I think I'm also thinking about the work of Dr. Gahn. So when you look, if you want to learn more, kind of look up culture as treatment or culture as prevention. Also some great work in Alaska as well.
Thank you, Dr. Lewis. And I think we've just gone a little beyond the 3 o'clock Eastern time, but we did get started a little bit late. So I think I want to be mindful of the time of all of our participants. Thank you so much for attending our webinar focused on advancing the Tribal Behavioral Health Agenda through greater awareness of diabetes and behavioral health comorbidities. Thanks to all of our presenters for your great information that you shared. I'm even more excited at the end of this webinar thinking about the possibilities of moving this forward and helping improve the well-being and lives of American Indian and Alaska Native people. As Sarah said, we will post a link to this webinar on our PRC website, within 24 hours. And so if you know of anybody who wanted to be here but couldn't, but who may enjoy this conversation, please help us spread the word. If you have any additional comments, please feel free to contact me directly or our PRC email address, which is research@ncai.org. Thank you so much for joining us today, and have a great rest of your day. Bye-bye.
Bye.